So I'm going to be talking about color Doppler sonography in GU ultrasound. And these are my disclosures. So anyway, before I talk about more specific applications of color Doppler in GU ultrasound, I thought I'd show you a couple of examples of where color Doppler is not only important, but it's actually critical in making the correct diagnosis. So this is the first case. This is a kidney. It looks like a normal kidney with what looks like a simple cyst in the inferior pole of the kidney. Who thinks it's a simple cyst? Well, nobody. One. Oh. Okay, well, I wouldn't be showing you this, a simple cyst, because with color Doppler, we see that it fills in, and we see this yin-yang appearance, characteristic yin-yang appearance. There's this area of aliasing, feeding this very large pseudoaneurysm, which occurred after a biopsy of this kidney. So this is a life-threatening condition, which we would not have made without color Doppler. Here's a movie showing that aliasing and then that flow going into and out of this large pseudoaneurysm. We did an MRI, which confirmed that this is a pseudoaneurysm, and then this patient was then able to be successfully treated with coil embolization. So color Doppler saved the day. Different patient, this is a transplant kidney. To my eye, on grayscale, it looks pretty normal, but with color Doppler, we see that the entire upper 2/3 of the kidney does not perfuse. There's no color here. Whenever we see something like this on color, it's nice to verify with power. Power is a little bit more sensitive for slow flow, so we have power here. There's still no detectable internal vascularity, so what looks normal on grayscale is actually a partially infarcted kidney transplant. And then finally, this is a different case. This is a case given to me by my colleague Shuchi Rogers from Einstein. This is a woman who came in with severe right upper quadrant pain. At our institution, when we do a right upper quadrant ultrasound, we still look at the kidney. And this helps to show why. So on grayscale, this kidney looks normal. But with color Doppler, we see that there is no detectable internal vascularity in this kidney, and this was a completely infarcted right kidney, which we would not have known if we had not looked at it with color Doppler. Okay, so those are some examples of where color Doppler is really critical, but I actually want to show you or talk about more specific applications of color Doppler. So I'm actually going to give you a brief background, kind of like a review from medical school about the kidney, and then we'll talk about color Doppler and evaluation of hydronephrosis, color Doppler and twinkling artifact and how that can help you, and then just briefly about the bladder. So going back to medical school, the kidneys are a pair of retroperitoneal organs that help to filter your blood, remove waste, and maintain your electrolyte balance, and it does this by excreting urine in various concentrations. The kidney also has some endocrine functions. So the kidneys secrete renin from the juxtaglomerular cells. They activate erythropoietin, which is important for red blood cell production, and convert vitamin D, which is important for calcium homeostasis. The renal parenchyma can be broadly divided into the cortex and the medulla, and the primary unit of the kidney is the nephron. The nephron, in turn, is composed of the glomerulus, where we have an afferent arteriole. It goes into a tuft of capillaries, and then an efferent arteriole, and that helps to filter the blood into Bowman's capsule, where that fluid is then taken to the proximal convoluted tubule, the loop of Henle, and then to the distal convoluted tubule, and it changes the concentration of the urine using this countercurrent osmolarity system. The urine then goes into the collecting duct and then into the ureters and bladder. So the cortex is where the glomeruli live. And just an aside, when you biopsy a kidney, you need to biopsy the cortex because we are trying to get glomeruli in order to make a diagnosis. And then the medulla is where the loop of Henle and the collecting ducts live. The juxtaglomerular cells are a set of smooth muscle cells that live in the afferent and efferent arterioles, and they detect the amount of blood going to the kidneys. And in response to low blood volume, they will secrete renin. Renin, in turn, activates the renin-angiotensin-aldosterone cascade, and that helps to regulate sodium chloride in water in your body. And also angiotensin 2 is a very potent vasoconstrictor. So that's why in patients who have refractory hypertension, we often do a renal ultrasound. We'll typically also do a renal ultrasound in patients who present with acute kidney injury, and that is defined as an abrupt decrease in kidney function within 7 days, where the creatinine increases by 0.3 milligrams per deciliter, or where you are oliguric with urine output less than 500 cc's over a 24-hour period. If it gets better within 48 hours, that is considered to be rapid reversal acute kidney injury, but if it goes on over 48 hours, that is persistent acute kidney injury. And then if it goes on for over 7 days, that is now acute kidney disease. If you have a GFR that is low, less than 60, and that's been going on for over 90 days, then you are in the chronic kidney disease realm. So in patients who present for the first time with acute kidney injury, or suspected acute kidney injury, the ACR does recommend doing an ultrasound as first-line imaging. And the reason for this is that the renal ultrasound can help to evaluate for potentially reversible causes such as hydronephrosis or poor perfusion to the kidney. And we can also assess for evidence of chronic kidney disease, which may have otherwise not been known in that particular patient. Okay, so that's a brief background. Moving on to color Doppler and evaluation of hydronephrosis. Okay, so urinary obstruction is a very common cause of acute and chronic renal failure, and I have to say that at our institution, it's one of the main reasons for doing a renal ultrasound. They always come in and say, rule out hydronephrosis. Well, it's not everything, but we are definitely looking for obstruction, and a secondary sign of obstruction is dilatation. With obstruction, typically patients will have symptoms such as flank pain, fever, nausea, vomiting, or hematuria. Sometimes they'll have recurrent UTIs. They may have polycythemia because of their erythropoietin. And then causes of obstruction can include calculi in the collecting system, tumors, strictures. We saw earlier cases of endometriosis obstructing the urinary system, and then you can have bladder outlet obstruction. So when we are assessing for collecting system dilatation, I think it's important to use vocabulary that is consistent. And so when we look at the collecting system, if the renal pelvis is dilated, we would call that pelviectasis. Color Doppler is really important in confirming pelviectasis to confirm that that is truly a dilated renal pelvis as opposed to vessels. This is a different patient who kind of looks like they have pelviectasis, but with color Doppler, we see that it actually fills in completely with color. So these are just prominent renal vessels. So color is really important in helping to differentiate between the two. Chaliectasis is where you have dilated calyces, and again, color Doppler is really helpful in confirming that those are calyces as opposed to prominent pyramids. But once you have dilatation of your renal pelvis as well as your calyces, then we would call that pelvochaliectasis, and most people accept that that is synonymous with hydronephrosis. That may or may not be accompanied with ureteral dilatation, and hydronephrosis can be obstructive hydronephrosis or non-obstructive hydronephrosis. So hydronephrosis is just a state of dilatation. It doesn't imply the reason for that dilatation. With hydronephrosis, we can then give kind of a gestalt or grade of the degree of dilatation that we see. And I would have to say that in the literature, there's not clear definitions. So I just took this from StatDX. In StatDX, they just say mild hydronephrosis is if you have mild dilatation of the collecting system. Moderate is when you have moderate dilatation and calyceal blunting. And then severe is where you have severe dilatation as well as renal parenchymal thinning or changes in the renal ecotexture. Okay, so when we evaluate patients with color Doppler, we typically also get a resistive index. And the resistive index should be measured in either the distal segmental or interlobar renal artery. The resistive index is calculated by taking the peak systolic velocity minus the end diastolic velocity divided by the peak systolic velocity. So you have velocity over velocity. That means it's unitless because the units cancel. This example here, we're angle correcting, but you don't need to angle correct because by angle correcting, you're just going to be dividing cosine of theta by cosine of theta. So that also cancels. So you actually don't need to angle correct. In the literature, the resistive index is accepted to be normal if it is between 0.5 to 0.7, elevated if it's over 0.7, and then low if it's less than 0.5. And if it's this low, then you start thinking about parvus tardus. So in my experience and in the literature, the resistive index is non-specific but helpful. So it's not perfect. It is a marker of renal dysfunction, and it is typically elevated with interstitial or vascular diseases, and we very frequently see high RIs with chronic medical renal disease. But you need to kind of put this into context with the patient, because the resistive index does increase with advancing age. So in somebody who's very elderly, a high resistive index may actually be normal for that patient. So you need to put it into context with the patient. And then another caveat about the resistive index is that it may actually be normal even in the presence of glomerular disease. And so we think that is the case because glomeruli only comprise 7% of the renal parenchyma, which is not a lot. And so that may not be enough to affect the resistive index. Okay, so this is a patient whose resistive index is pretty high, but if you look at this carefully, who believes it's diastolic flow? Oh, nobody. You guys are so smart. Okay, so this is not real diastolic flow. This is intrinsic machine noise, which we call clock phase jitter. And it is symmetric above and below baseline. It is, you see it in all silicon electronics. It's very hard to get rid of. And that clock phase jitter can obscure the true diastolic flow. So if you use the clock phase jitter as your end diastole, you will actually underestimate your true resistive index. And that can lead to errors in interpretation. So in this patient, we redid it and redid the resistive index, and you can see there's still a little bit of clock phase jitter. I don't know if it projects, but we're able to make it less apparent, and there's actually no diastolic flow here. So the resistive index is really close to 1 in this person. The resistive index may also be elevated in patients who have acute high-grade obstructive uropathy. But again, there are some caveats with this. So there's this narrow window where the resistive index is typically elevated between 6 to 48 hours after the onset of symptoms. This is a patient who has some mild hydronephrosis. I would say the resistive index is mildly elevated, 0.76 on the left kidney. That is asymmetrically elevated compared to the right, which is only 0.66. In the literature, it's felt that if you have a resistive index difference of 0.06 to 0.1, that is significantly different. In this patient, difference was caused by this UVJ stone, which you can see because of twinkling artifact, which we'll talk about next. So in the setting of hydronephrosis, the resistive index has gotten kind of a bad rap, I would say. So first of all, it may not be elevated in partial obstruction, and if you have a forenasal rupture, your resistive index may also not be elevated, so it's not perfect. When it was first described by Joel Platt, also from Michigan, in 1989, a long time ago, the diagnostic performance was reported to be excellent, 92% sensitivity and 88% specificity in differentiating obstructive hydronephrosis from non-obstructive hydronephrosis. And so everyone thought that was the greatest thing. But then a few years later, Mitch Tublin and a few others reported their experience with the resistive index, and their diagnostic performance was not nearly as good, with only a 44% sensitivity. So we think that actually the resistive index in the setting of obstruction is affected by other things, such as NSAIDs that can cause vasodilation and then can cause your resistive index to decrease. The degree of hydration, whether you got IV contrast, that can affect your kidneys, and then your imaging technique, like I just showed you with the clock phase jitter, that can cause errors in your resistive index measurement. Okay, so that's just a little bit about hydronephrosis. Moving on to color Doppler and twinkling artifact. It is twinkling artifact, not twinkle. I've heard a lot of people say twinkle. Twinkle is incorrect. It was first described by Ramuni et al. He's a Frenchman, I guess, from 1996. And so it might not sound correct to native English speakers, but twinkling is a gerund. And so if you want to be correct about it, it is twinkling artifact. Okay, anyway, so twinkling artifact, it's a color Doppler artifact. And what you'll see is this alternating red and blue color Doppler signal, and actually all colors of the spectrum seen behind a rough, highly reflective surface. And we think twinkling artifact occurs because of amplification of this intrinsic machine noise, this clock phase jitter. So what happens is you have a transducer here, it sends a brief pulse of sound and hits this rough surface. That sound gets reflected back to the transducer and the machine interprets that location. The machine sends another brief pulse of sound. It thinks it's hitting this spot, but it's actually a slightly different spot. That slightly different spot has a different path length, and that gets interpreted as a frequency shift. And then that gets interpreted as motion. When nothing has moved, it's just a rough, highly reflective surface. Okay, so this is what clock phase jitter looks like. I am using in this example, this is an image from this paper that I wrote a long time ago looking at twinkling artifact, and we used a pipette holder to image a flat surface. And so you get this clock phase jitter if you image even just a flat, non-living surface. That gets amplified with twinkling artifact. And so with twinkling artifact, you get this broad-banded spectrum that fills the whole spectrum symmetrically above and below baseline. So that's what twinkling artifact looks like on spectral Doppler. And I think one of my CMA questions is how can you tell if it's twinkling artifact? If you want to be sure, you put a spectral tracing on it, you'll get this waveform. Okay, so a twinkling artifact, it's something that we see all the time. We see it with kidney stones, gallstones, adenomyomatosis, as well as biliary hamartomas, and then calcifications in other places like vascular calcs, pancreatic calcs, you name it. With twinkling artifact, it's useful because it is not affected by the ultrasound beam. So sometimes, the focus of your ultrasound beam. So sometimes you'll see an area of twinkling where you're not actually focusing on, and it helps to draw your eye to that spot. It's also not affected by the ultrasound frequency. But it is affected by other machine parameters, such as color right priority. If you increase your color right priority, you'll increase the amount of twinkling artifact that you see. If you increase your grayscale gain, you'll decrease the amount of twinkling artifact you see. And then if you increase your PRF, you'll actually decrease the amount of twinkling that you see. Okay, so here are some examples of where twinkling artifact can be helpful. This is a patient who has kidney stones on grayscale. I think it's kind of hard to see. Sometimes stones, they kind of blend in with the renal sinus fat. The sonographer here put calipers because they thought that was a stone. But with color Doppler, we can see that, oh, there's twinkling artifact here. So maybe it is a stone, and there's another spot here with more twinkling artifact that helps us to draw our eye back to the kidney. Oops, my arrows. And the second area of twinkling corresponds to this other echogenic focus that maybe I didn't see as well originally. And then we can confirm that that is twinkling artifact and not aliasing by using spectral tracings over it, and we see this broad-banded spectrum. Different patient where the kidney is a little bit tough to see. There's this echogenic area. With color Doppler, we can see that there is twinkling artifact. That helps us to draw our eye back here, and we can see this barely perceptible posterior acoustic shadowing that corresponds to that area of twinkling artifact, and we can be sure that that's twinkling artifact by putting a spectral tracing on it. And you see that broad-banded spectrum, and that corresponds to this kidney stone here. So if you want to be absolutely sure, or very, very sure that you're really looking at a kidney stone, you can't just rely on the twinkling artifact. So you need to use your other sonographic features, and that includes an echogenic focus, posterior acoustic shadowing, and then twinkling artifact is very helpful. Here's an echogenic focus, posterior acoustic shadowing, and twinkling artifact. Another example where we have this echogenic focus, posterior acoustic shadowing, and twinkling artifact. So there was a paper, a really nice paper, a couple of years ago by Bill Mash et al., also from Michigan. Michigan's just a powerhouse, I guess. Run. Okay, fine. Anyway, so so there's a paper that was published 2 years ago by Bill Mash et al. Looking at twinkling artifact and kidney stones. And they looked at these three sonographic features: echogenic focus, shadowing, and twinkling artifact. If you only use twinkling artifact in their paper, they had a positive predictive value for stone of 68%. But if you add additional sonographic features like an echogenic focus, you increase your positive predictive value to 74%. And then if you add shadowing, you increase that positive predictive value to 92%. But you're going to be much more specific for stone if you use all three, but your sensitivity goes way down to 31%. So it's a compromise. If you can use twinkling to help improve your sensitivity, that's great, and then you kind of complement that with these other sonographic features to improve your positive predictive value. And there's another paper also from University of Michigan looking at just twinkling artifact in diagnosis of stones, and this is a paper by Jonathan Dillman et al. From 2011, where they compared twinkling artifact to 5 millimeter slice non-contrast CTs. So if you only use twinkling and none of the other sonographic features, you're actually only going to be correct 50% of the time, or close to 50%. So in their paper, if they only looked at twinkling, the positive predictive value for stone was 78% anywhere in the kidney. But if you look look at each individual focus, the true positive for stone was actually only 49%. And they had a 51% false positive rate. So you're only going to be correct 50% of the time if you only rely on twinkling. That's why you need to use your other sonographic features. And the reason for that is that not all stones have twinkling artifacts. So here's an example of a pretty obvious stone to my eye. There is this echogenic focus and shadowing, but there is no corresponding twinkling artifact. So twinkling is not perfect. Not all stones have twinkling. A different example of a distal ureteral stone with shadowing, but there is no twinkling artifact. So it's not perfect. And then the converse is also not true. Not all twinkling equals stones. So in the kidneys, we see twinkling artifact very commonly in debris layering in cysts. And here's an example. So this patient has lots of areas of twinkling artifact. You need to look at that carefully with grayscale. In this patient, we see that that area corresponds to this little cyst, and there is layering debris here. That layering debris, for some reason, is really, really prominent on color Doppler as twinkling artifact very frequently. And this is the same patient on CT that corresponds to that little tiny cyst. That layering debris sometimes is way more obvious on ultrasound than on CT, in fact. It's not calcified on CT in many cases. A different patient where we have lots of twinkling, and there you can see that there's layering debris within the cyst, and that corresponded to a cyst with a little bit of layering debris you can see on the MRI. You can also have twinkling artifact in layering milk of calcium, which we can see with larger cysts or with calycyl diverticula, and this is a patient who has very prominent shadowing and really prominent twinkling artifact. Twinkling artifact is really helpful in looking at UVJ stones. When we look at the bladder, we typically look for ureteral jets. And in this patient, we have a unilateral jet on the left side, no jet on the right side. But with color Doppler, it's really nice to put that window just over the UVJs. That helps us to identify this little stone with their twinkling artifact here. I think twinkling is really helpful in looking for UPJ stones. Sometimes stones in the UPJ are really hard to see because they're kind of deep or they may be obscured by bile gas. In this patient, they have mild to moderate hydronephrosis, kind of hard to see. Maybe you see it because you guys are all great at ultrasound, but hard to see on the grayscale. But when you look at it with color Doppler, you can see this area of twinkling artifact, really obvious, and that corresponded to this stone that in retrospect was actually there. I have some stills here. Here's a twinkling artifact that really helped us identify this UPJ stone. This person did go on to CT, and there is a stone here. Okay, so that's twinkling artifact. Moving on to color Doppler in looking at the bladder. So going back to obstruction and hydronephrosis, this is a patient who has asymmetric dilatation of the collecting system on the right compared to the left. Whenever we see this, we want to look at the bladder. And when we look at the bladder, what we're looking for are the jets. The jets are really helpful. In this patient, they have a left-sided jet, but no right-sided jet. So unilateral jet, or ipsilateral jet is absent, and that was caused by an obstructing right-sided UVJ stone. So jets are really helpful in figuring out whether your obstruction is complete or high grade versus partial or incomplete. So if you have a unilaterally absent jet, that actually corresponds very well with high grade obstruction, with the caveat that the urine that's coming into the bladder needs to be of a different tonicity than the urine within the bladder. Jets typically are best seen with color Doppler. And they're usually 1 to 3 seconds in duration. They'll alternate depending on the peristalsis. And the frequency of the jets appearing actually depends on how well hydrated the patient is. So if the patient has not been drinking for a long time, you may not be able to see their jets. And then typically you want the bladder to be at least moderately full to help improve your jet visualization. So usually we see jets with color Doppler. Sometimes we see jets with grayscale. I don't know if that projects, but there's some grayscale jets here. Different patient where, I don't know why the right jet you can see with grayscale, and then the left jet you can see with color Doppler. So it's good to look at the jets in both grayscale and color. Different patient who has mild hydronephrosis of the kidney, and we can see the cause. There's this UVJ stone here. You can see that it's trying to make its way into the bladder. We look at it with color Doppler, and we can see that there is this low amplitude continuous jet, which is a pattern that we sometimes see with partially obstructing UVJ stones. So again, color is really helpful in showing that this is not a high-grade obstruction, it's a partial obstruction. Color is really helpful in looking at bladder stones. This patient has bladder stones. To my eye, I think it's hard to see on grayscale. Maybe you guys see it, but with color we can see all of this twinkling artifact, and that corresponds to this area of shadowing. And this patient did have a CT. I can't remember if it was before or after the stones. They're mobile, so on the CT they're on the opposite side, but you can see these layering little tiny stones. And then finally, an obvious example where color Doppler is really helpful in looking at the bladder. This person had gross hematuria. They have this large mass-like thing in the bladder. Is this a hematoma or is this a tumor? Well, with grayscale, it's a little bit tough to tell, but with color Doppler, we can see that there's internal vascularity, and that has arterial waveform, so that is clearly a bladder cancer. Okay, so in conclusion, color Doppler is really useful in GU sonography. It's really important in global assessment of the kidneys and collecting system, in evaluation of patients who have obstruction and hydronephrosis. Color Doppler twinkling artifact is really helpful in identifying kidney stones, but it's not perfect. You need to use those additional sonographic features to improve your specificity. And then color Doppler is helpful in evaluation of the bladder, especially those jets. Thank you so much.